Hello everyone, welcome back to the series of lectures in medicine. So we'll be starting off with a very important and interesting unit which is hematology, and under hematology today we'll be discussing about hemolytic anemias. So let us start. So first let us understand what exactly is anemia. So anemia, as per definition of the WHO, is defined as a decrease in the hemoglobin, right? So hemoglobin which is less than 12 milligram per deciliter in non-pregnant female or less than 13 milligram per deciliter in male. Okay, so this is the cutoff that we should be aware of. So less than 12 in females and less than 13 in males, and if you take a pregnant female, then the cutoff is less than 11 milligram per deciliter in pregnancy. Okay, so this is how WHO defines anemia. Alright, fine. Now, another very important concept that we should understand before moving on to hemolytic anemias is the concept of reticulocyte production index. Okay, so we know that reticulocytes are basically immature RBCs which are produced from the bone marrow and released into the blood. So in conditions such as anemia, there is going to be increased compensation by the bone marrow, correct? So when there is going to be an increased compensation by the bone marrow, more and more of immature RBCs will be produced in the marrow and released into the blood. So that is what is a reticulocyte. So we should be aware of the reticulocyte productive index to know what type of anemia this is. Okay, fine. So reticulocyte production index, how will you calculate that? You have a step 1 and a step 2. Okay, so in the step 1, we need to correct the reticulocyte for the anemia. Right, so we need to correct the reticulocyte count for the anemia. So how do you know that? So you will get a normal CBC done in a patient whom you are suspecting anemia, and the CBC will show the reticulocyte percentage. Okay. Now this reticulocyte percentage has to be corrected for the degree of anemia in an anemic patient. Right. So this reticulocyte percentage correction you get by the reticulocyte percentage which is given in the CBC into the hematocrit. Hematocrit is nothing but the PCV by 45. Okay, so that is the first step. You need to get the corrected retic count. Okay, so this is what we call as the corrected reticulocyte count. Okay, so very important is to calculate the reticulocyte production index. The first step is to identify the corrected reticulocyte count. What is it corrected for? It is corrected for the degree of anemia. The degree of anemia can indirectly be also measured by the PCV. Okay, so the reticulocyte percentage which you obtain in the CBC multiplied by the hematocrit by 45 gives you the corrected reticulocyte count. Okay, that means to say that in an anemic patient, what is the expected PCV or the expected hematocrit will be lower. What is the normal hematocrit? The normal hematocrit or PCV is going to be taken as an average of 45. Okay, so for the anemia, the reticulocyte percentage will actually be higher in the CBC, but you need to know the corrected reticulocyte count. So that is why you need to multiply it by the hematocrit by 45. So that is the first step. Second step in the calculation of the reticulocyte production index is you will have to correct it for the longer life of the prematurely released reticulocytes. So whenever there is anemia, the bone marrow is going to try and compensate for it, and there is going to be a premature release of the reticulocytes from the bone marrow into the blood. Right? So for that, what you should understand is this concept of maturation factor. Right? So whatever reticulocytes which are prematurely released are going to be in the blood for a longer time. So to understand the reticulocyte production index, you need to identify the maturation factor. So let us understand this with the help of this diagram. So let us see when the hematocrit is at 45, which is grossly considered to be the average normal value, you see that the marrow reticulocytes usually spend up to an average of 3.5 days in the bone marrow, and once they are released into the blood, their duration or the duration or the time that they spend in the peripheral blood is only 1 day. But now as the hematocrit decreases, which means what? So you can see here that the hematocrit is decreasing 35, 25, 15, which means what? The degree of anemia is increasing. The degree of anemia is increasing. So when the degree of anemia is increasing, then the immature reticulocytes are released from the marrow as a compensation, and hence they are going to spend a longer time in the peripheral blood, right? So when the hematocrit is at 35, the reticulocytes are going to spend about 1.5 days in the peripheral blood. If the hematocrit drops to 25, then the peripheral blood reticulocyte is going to spend around 2 days in the peripheral blood, right? So this kind of change, or the number of days that the reticulocyte is going to be in the blood, will also have to be accounted when you're going to calculate the reticulocyte production index, right? So this shift is what we call as the correction factor or the maturation factor, and normally we take the average maturation factor to be a value of around 2, because in anemia the average hematocrit is around 25. Alright, so let us just go back to the previous slide and understand what I'm saying. So the second step when you are calculating the reticulocyte production index is the correction for the longer life of the prematurely released reticulocytes. Okay, so now you are able to understand what is the meaning of this sentence. So how will you do that? So you do that by the corrected reticulocyte count, by the maturation factor. So if the maturation factor you are not able to remember whether this is 1 or 1.52 or 2.5, just remember the value 2, which is usually taken as the average, and you take the corrected reticulocyte count by the maturation factor, which is 2. Okay, fine. So let us just put things back into perspective. What are we learning? We are learning about the approach to hemolysis, in that how will you classify anemia? Anemia is classified on the basis of the reticulocyte production index. So what are reticulocytes? Reticulocytes are basically immature RBCs which are released from the bone marrow as a compensation whenever there is anemia. Right? So when you have to calculate the reticulocyte production index, you have to calculate the corrected retic count, which is basically given by reticulocyte percentage, which you obtain from the CBC, into hematocrit by 45, and then you also have to correct it for the time frame that the immature reticulocyte spends in the blood, and that is given by the corrected retic count by the maturation factor. So let us look at this with the help of an example. Okay, so how do you calculate the reticulocyte production index? So first is the correction for anemia. So let us say that a person has anemia and the reticulocyte count is 9%, then the hemoglobin is 7.5 and the hematocrit is 23%, right? So how will you get the corrected retic count? It is given as 9 into 7.5 by 15 or into 23 by 45, which is usually the hematocrit by the average 45, which is the PCV. Okay, so 9 is the retic count, 9 is the reticulocyte percentage into the hematocrit by PCV. Okay, so this hematocrit by PCV is 23 by 45. Hematocrit by the actual PCV, which we consider as the average, and what is the retic percent here? It is 9. So this gives us the corrected retic count of 4.5. Fine. Now, the next step in the calculation of the reticulocyte production index would be to correct it for the maturation factor, right? So here, what would be the maturation factor? PCV is 25%. So maturation factor will be 2. So you will have to divide it by 2, which is equal to 2.25. So if anybody asks you, how will you calculate the reticulocyte production index? This is how you do it. All right, clear. Now, why is this calculation for reticulocyte production index so important? That is because you can classify and identify the etiologies of anemia based on the reticulocyte production index. Alright, clear? So that's the reason why you need to be aware of the reticulocyte production index. So if the reticulocyte production index is less than 2.5, then this is called as a hypoproliferative anemia. Hypoproliferative anemia. Okay, so this is called as a hypoproliferative anemia. That means that the problem is at the level of bone marrow, there is some amount of hypoproliferation. The bone marrow is not able to compensate for the anemia adequately. Okay. So, then you look at the MCV and you see if the MCV is low, then you are probably dealing with an iron deficiency anemia, or you are dealing with a sideroblastic anemia. Okay. If the MCV is high, you are dealing with a B12 or a folate deficiency anemia. Okay. So, this is about hypoproliferative anemias. Now, if the reticulocyte production index is more than 2.5, then you are dealing with a hyperproliferative anemia. And what are those hyperproliferative anemias? They are the hemolytic anemias. Okay, right? So, hypoproliferative, iron deficiency, sideroblastic, B12 and folate deficiency, which is basically your megaloblastic anemia, and RPI more than 2.5, hyperproliferative anemia, which is your hemolytic anemias. Clear? So, this is about how you would approach RPI and how will you classify anemias based on the reticulocyte production index. Alright. So, now we will move on to hemolytic anemias. So, what exactly is hemolytic anemias? Hemolysis, as the name suggests, refers to breakdown of RBCs. So, there is breakdown of RBCs. Okay. So, this is what you mean by hemolytic anemias. So, how do you classify hemolytic anemias? So, hemolytic anemias can be classified as intracorpuscular and extracorpuscular defects. That means that there can be defects due to problems within the cell membrane or within the RBCs, or hemolysis can also occur due to defects which are from outside the RBCs, which is an extracorpuscular defect. Also, hemolytic anemias can be classified as whether this is an inherited hemolytic anemias or an acquired hemolytic anemia based on the etiology. Okay, so this is how you classify it, and this is how the table is made, right? So, whenever you look at inherited hemolytic anemias, that means it occurs due to a genetic defect with the RBC, right? So, this can be due to hemoglobinopathies. So, what do you mean by hemoglobinopathies? Hemoglobinopathy means a disorder which affects the hemoglobin synthesis, right? So, a disorder which affects the hemoglobin synthesis. So, example of hemoglobinopathies include thalassemia and sickle cell anemia, right? Thalassemia and sickle cell anemia, which are problems with the hemoglobin production or hemoglobin chains, is your hemoglobinopathies. Then, the next cause for inherited hemolytic anemias include enzymopathies, where there is a problem in the glycolytic pathway which is used by the RBC for its function. So, there can be G6PD deficiency, pyruvate kinase deficiency. These are enzymopathies. Then you can have membrane cytoskeletal defects, which means defects with the RBC membrane. So, defects in the RBC membrane is going to cause RBC damage, and this is example of a membrane cytoskeletal defect causing inherited hemolytic anemias, and all of these are intracorpuscular defects, defects within the RBC. Then there can be certain inherited defects which usually occur with extracorpuscular factors as well. So, what is that one inherited syndrome which predisposes to hemolysis because of extracorpuscular defects? And this is a familial or an atypical hemolytic uremic syndrome. Alright, clear? Fine. Now, let us look at the acquired causes for hemolytic anemias, right? So, when we speak about the acquired causes, we have to remember that acquired causes often are associated with extracorpuscular defects, right? So, one exception which you can remember is PNH, where there is an intracorpuscular defect, but it is acquired. Okay, we will be looking at PNH more in detail a little later. Then, when we look at acquired causes due to extracorpuscular factors, it can be because the RBCs are getting destroyed due to some mechanical factors, which we call as the MAHA or the microangiopathic hemolytic anemia. It can be due to drugs, toxins, infections, autoimmune hemolytic anemia. So all of these are examples of acquired causes of hemolytic anemia due to extracorpuscular factors. Clear? So this is how you classify the hemolytic anemias. Now, let us understand what are the common features to a patient who is presenting to you with a suspected hemolytic disorder, right? So, what are the certain things that you have to look for and certain things which will make you think that okay, this patient may be having a hemolysis that is contributing to his anemia, right? So, first of all, in general physical examination, there will be evidence of jaundice, there will be evidence of pallor. Now, why is there pallor? Obviously, because the hemolysis is triggering abrupt decrease in the hemoglobin and hence the patient will be pale. Now, why is there jaundice? Right? So, jaundice is predominantly because of the breakdown of RBCs result in what type of hyperbilirubinemia? It results in indirect hyperbilirubinemia. Indirect hyperbilirubinemia. So, the very important test other than hemoglobin which you have to look into is indirect hyperbilirubinemia in your liver function test. Right? Because bilirubin is a breakdown product of heme. That is the reason why when there is hemolysis, there is going to be indirect hyperbilirubinemia. Okay? Fine. Then what are the other physical findings which you will watch out for? You may look for splenic enlargement. We know that the spleen is the graveyard of the RBCs and hence any hemolysis can result in a splenic enlargement, especially when it is an extravascular hemolysis. Hemolysis is happening in the extravascular spaces like the spleen. Then, in congenital or hereditary causes, especially thalassemia. In thalassemia, you can have bossing of the skull. Then, the other test you will have to look is definitely a hemoglobin level. Then, you will have to look for the MCV and the MCH, mean corpuscular volume and the mean corpuscular hemoglobin, which is usually increased. And whenever there is hemolysis, the bone marrow is going to compensate for that. And just now we had seen this. There will be a hyperproliferative anemia. If a hyperproliferative anemia is there, then what are you going to find? You are going to find reticulocytosis, usually increased. So, there is going to be reticulocytosis. Fine. Then, what happens to the bilirubin? It is increased and it is an unconjugated or an indirect hyperbilirubinemia. Then what happens to the LDH? LDH is also another very important marker which is usually increased in hemolysis, and the other important marker is haptoglobin, to which the heme is usually bound, and this is reduced to absent in hemolysis, especially in intravascular or hemolysis which is happening within the vessels. Okay, fine. So this is something that we should be very clear about. There can be increased MCV, increased MCH, the hemoglobin will be reduced, there will be reduced haptoglobin, there can be increased LDH, and you may find evidence of indirect hyperbilirubinemia and reticulocytosis. So these are some of the features which are common to most of the patients with a hemolytic disorder. Now let us understand what is the difference between intravascular and extravascular hemolysis. So intravascular hemolysis means the hemolysis is happening within the vessels. Okay. Extravascular means that the hemolysis is happening outside the vessels. It is happening in sites like the spleen and the liver, which are the graveyard of RBCs, and the RBCs are getting broken down there. So let us look at some of the most important differences. We have looked at the common features, but we'll also have to look at the differences between intravascular and extravascular hemolysis. So first is what will you see on the peripheral smear? So on the peripheral smear in an intravascular hemolysis, you may find evidence of schistocytes. You may find evidence of schistocytes. Now what are schistocytes? Schistocytes basically means that the RBCs are broken down. The RBCs are broken down. So you will have broken down RBCs, which is called as schistocytes, whereas you may find the evidence of spherocytes in the extravascular hemolysis. Okay, so this is your extravascular. In extravascular hemolysis, you may find evidence of spherocytes. Okay, so remember, spherocytes are not found only in hereditary spherocytosis. They can be found in any form of extravascular, including AIHA. Okay, then characteristic feature of intravascular hemolysis is that what happens in intravascular hemolysis? There is hemolysis within the vessels, and hence the RBCs, broken down RBCs, will reach the kidney and they get excreted in the urine, and hence you will have hemoglobinuria and hemosideruria, which is found in the intravascular hemolysis, which is not found in extravascular. Okay, fine. What happens to the haptoglobin? Haptoglobin is reduced in intravascular as well as extravascular hemolysis. Okay, then what happens to your direct Coombs test? The direct Coombs test is usually positive in the extravascular hemolysis, which is not positive in the intravascular. And splenomegaly is seen in what? So if we just apply our common sense, extravascular hemolysis is where there is destruction of RBCs in the graveyard of RBCs, which is the spleen, and hence splenomegaly is seen in extravascular hemolysis, which is not seen in intravascular hemolysis. Okay, so these are the major differences between intravascular and extravascular. Okay, so always remember hemoglobinuria, hemosideruria, this is found in intravascular, whereas splenomegaly is more common in extravascular hemolysis. Alright, fine. So now with this we have understood the basic approach. Let us understand the etiologies for hemolysis. So what are the causes for hemolysis? We have looked at this slide prior. I am just trying to reiterate this again. So this can be inherited causes as well as acquired causes. So certain things that you have to remember is that most of the inherited hemolytic anemias are usually due to intracorpuscular defects like hemoglobinopathies, enzymopathies. Okay, except, what is the exception? It is atypical HUS. And remember, inherited hemolytic anemias usually have extravascular hemolysis, in the sense most of them will present with a splenomegaly. Most of them are going to present with splenomegaly, and they do not have your hemoglobinuria, hemosideruria and so on. Most of the acquired causes are due to extracorpuscular defects, and the only exception that you'll have to remember is PNH, which is paroxysmal nocturnal hemoglobinuria. And remember, extracorpuscular defects are usually associated with intravascular hemolysis. Okay, so here is where you'll have your hemoglobinuria, hemosideruria. Clear? So this is about certain important points that you have to remember when you speak about the causes and the important exceptions to the rule. Right? So till here we have understood the approach to hemolytic anemias. Now let us look at the etiologies one by one. So now let us look at the inherited hemolytic anemias. So inherited hemolytic anemias can be due to hemoglobinopathies, as we have previously discussed. So hemoglobinopathies include disorders which are associated with a hemoglobin defect, which includes thalassemia and sickle cell anemia. Then the inherited hemolytic anemias can be due to membrane defects. So membrane defects include hereditary spherocytosis, hereditary spherocytosis and hereditary epileptocytosis. Inherited hemolytic anemias can also be due to enzymopathies. What are the enzymes? Enzymes predominantly of the glycolytic pathway, which includes G6PD deficiency. G6PD is glucose 6-phosphate dehydrogenase deficiency, which is an important enzyme of the glycolytic pathway, as well as the other enzymes which can be affected includes pyruvate kinase deficiency. Okay, so these are some of the examples for inherited hemolytic anemias. So let us start off with the membrane cytoskeleton defect, which is hereditary spherocytosis, right? So as the name suggests, hereditary spherocytosis, what will you expect in the peripheral smear? You will expect the presence of spherocytes in the peripheral smear. So this is an inherited cause of hemolytic anemia, which is due to a membrane cytoskeleton defect. And since this is an inherited cause, what you have to remember is that the most common type of hemolysis here is an extravascular hemolysis. Right? So what is the defect? The defect is in the membrane cytoskeleton. Okay? Membrane cytoskeleton means what? It is the RBC membrane. So this is the diagram which is basically depicting the various proteins which are found in the RBC membrane. Okay, so what are the proteins that you have to remember? You have to remember the band 3, right? So band 3 is basically a transmembrane protein. Apart from that, you have to remember ankyrin, you have to remember spectrin, right? So these are some of the most common protein defects which are associated with hereditary spherocytosis. Okay, so what you have to understand is that if there is a protein in the cell membrane of the RBC which is traversing the entire RBC membrane like this, so what is that protein? As you can see here, the protein here is band 3, right? So when the band 3 is affected, this is going to cause a spherocyte. It is going to cause a spherocyte, right? But if the horizontal protein is affected, if the horizontal protein like a beta spectrin or an alpha spectrin is affected, then what can you understand by logic? The RBC membrane is going to contract in this way and the RBC membrane is going to get slightly elongated, right? So this results in an epileptocyte. Okay, because these membranes are basically responsible for holding the RBC together and conferring its biconvex structure, right? So if the vertically arranged proteins are affected, you are going to get a spherocyte, whereas if the horizontally arranged molecules are going to get affected, you are going to get a hereditary epileptocytosis. So this is a small basic funda that you have to remember, and then remembering rest of the things becomes very easy. Okay, so let us understand the inheritance and what are the proteins that are usually affected. So the most common type is an autosomal dominant fashion, and ankyrin more than band 3 mutations are affected, and this usually results in hereditary spherocytosis. If the defects are usually inherited in an autosomal recessive pattern, which is the beta spectrin, then it usually results in a hereditary epileptocytosis. Okay, fine. So these are the protein defects which you have to remember. Ankyrin and band 3 resulting in hereditary spherocytosis, autosomal dominant fashion. Autosomal recessive hereditary epileptocytosis can be due to beta spectrin deficiency. Alright. Also you have to remember this band 3 protein is a very important protein which is associated with hereditary spherocytosis. It is associated with ovalocytosis, Southeast Asian ovalocytosis, and it is also associated with stomatocytosis, which basically means that the RBC becomes like a stomatocyte. Okay, so band 3 mutations are associated with which all types of hereditary spherocytosis forms includes hereditary spherocytosis, ovalocytosis and stomatocytosis. Okay, it's fine. So let us understand the pathogenesis. So what exactly happens in the pathogenesis of hereditary spherocytosis? So first step is that there is a membrane cytoskeleton defect, right? So there is a membrane cytoskeletal defect. Now this membrane cytoskeletal defect basically results in the formation of an unstable RBC membrane, right? So the proteins are required for the normal RBC biconvex structure, right? But here if the proteins are defective, then the biconvex structure cannot really be maintained and the membrane becomes unstable, right? This results in certain microvesicle formation on the membrane. Okay, so there can be formation of microvesicles, and after that the microvesicles can also bud off, right? So they pinch out and they can get degraded. Now what happens then? The RBC tries to maintain the least surface area to volume ratio. It tries to maintain the least surface area to volume ratio, and how does it maintain that? It maintains that by forming spherocyte. Okay, it maintains that by forming a spherocyte. Now till here that is also fine. But where does the RBC circulate? Finally, it goes to the graveyard of the RBCs, which is the spleen. So when the RBC then moves to the spleen, the diameter of the RBC is much higher than that of the diameter of the splenic capillaries, and hence here the RBCs undergo breakdown, resulting in extravascular hemolysis. Okay, so I hope this is clear. So membrane cytoskeletal defects basically result in the RBC assuming the shape of a spherocyte, just so that it can have the least surface area to volume ratio, and then it undergoes sequestration in the spleen and it breaks down. Okay, so this is the pathogenesis of hereditary spherocytosis. Now let us understand the common clinical features. So whenever a patient with hereditary spherocytosis presents with you, they are definitely going to have an anemia. Most often it is a chronic extravascular anemia. Okay, fine. Then yes, they will have splenomegaly because the RBCs are undergoing extravascular hemolysis. Can there be an acute presentation? Yes, if they have a superadded infection with the parvovirus B19. If they have a superadded infection with parvovirus B19, then this can cause bone marrow aplasia and resulting in an aplastic crisis. So they can have acute exacerbations or acute falls in the hemoglobin because of aplastic crisis. Okay, right? Also, they have a predisposition for gallstone formation, predominantly because of extravascular hemolysis. The bile becomes saturated with the hemolysis and excessive amount of indirect bilirubin, resulting in what type of gallstones? It results in pigment gallstones. So pigment gallstones, as you will recollect from your surgery classes, that it is a very, very important characteristic of hemolytic anemias. So recurrent episodes of jaundice, intermittent jaundice, predominantly because whenever they have a hemolytic episode, they can have intermittent jaundice, pigment gallstones, splenomegaly and anemia, right? So this is clear, and this is actually something that is very common to most of your inherited or your extravascular anemias. Now, let us look at the investigations for hereditary spherocytosis one by one. So, first and the basic test that you will do is the peripheral smear, and what will you find? You will find the presence of spherocytes. Can you see here? So, these are the spherocytes. So, you will find the presence of spherocytes in the peripheral smear. Okay, then you will have to look at the hemoglobin indices. Now, what will you see in the hemoglobin indices? MCV may be reduced, but the mean corpuscular hemoglobin concentration is definitely going to be increased. It is definitely going to be increased, mainly because once you assume the shape of spherocytes, the concentration of hemoglobin in that particular RBC will be increased, right? So, what are the other special tests which can be used in the diagnosis of hereditary spherocytosis? So, just by seeing a smear, you cannot say that the patient has hereditary spherocytosis, because I had mentioned that spherocytes can be seen in any type of extravascular hemolysis, including an autoimmune hemolytic anemia. So, that is the reason why you have certain specific tests. So, the first test, let us understand, is the SDS page electrophoresis, which is basically hemoglobin electrophoresis, which helps in identifying the proteins, right? So, it helps in identifying the membrane cytoskeletal proteins, and when you undergo electrophoresis, you get specific bands at which each protein should be there, and you do a comparator and you see where the defect is. For example, let us see that this is basically gel electrophoresis, and you see the movement of each of the proteins with respect to their charge and speed, correct? So, this is a normal patient, and you see that each of the proteins will basically appear as a band in the gel electrophoresis. So, you can see that this is where each of the pointers will be. So, spectrin would have moved the fastest, and then ankyrin, then we have band 3, protein 4.1, 4.2, band 5, 6, 7 and so on. So, can you see that in this patient there is no spectrin, right? So, you do not find evidence of spectrin that you can see here, right? So, this means that this patient is having spectrin deficiency. So, this is the SDS page electrophoresis, which is a type of gel electrophoresis, which basically detects the different types of membrane cytoskeletal defects based on the movement and charge of each of the bands. Okay, so this is about your SDS page electrophoresis. Now let us understand the next test, which is called as the osmotic fragility test. OFT stands for osmotic fragility test. Okay, so what do you mean by osmotic fragility test? So in this osmotic fragility test, what do? You basically incubate the RBCs in different concentrations of normal saline, right? So you incubate them from hypotonic to normal to a hypertonic normal saline, right? So if you are placing the RBC in a hypotonic solution, what is the expected outcome? So if this is where the RBC is, then in a hypotonic solution, the fluid is going to move inside the RBC and the RBC is going to swell up, right? But if you are going to place the RBC in a hypertonic solution, right? So if you are going to place the RBC in a hypertonic solution, the fluid is going to move out and the RBC is going to get dehydrated. So this is the basic principle at which you are seeing how fragile the RBC is at what type of osmotic concentration, and this is what we call as the osmotic fragility test. So first let us understand how the tubes will appear, right? So first let us see normal individual. Okay, so this is how the tubes are and they are arranged according to the sodium chloride concentration. Okay, so in a normal individual at 0.5% concentration of normal saline, you can see that the supernatant is clear and the RBCs are settled down, which means that there is no hemolysis. Okay, but now as the osmolarity goes on reducing, that means it's becoming more and more hypotonic, then what happens? The RBCs are going to swell up and you are going to find hemolysis. That means the supernatant is getting redder and redder as we go this way. Okay, but in a patient with hereditary spherocytosis, what are you seeing? You are seeing that in a higher concentration, that is in a hypertonic saline itself, with a concentration of 0.6 or 0.7 itself, the hemolysis is starting. Okay, that means that the hereditary spherocytosis patient, the RBC is very, very fragile. It is very, very fragile. Okay, so here it is already in a spherocyte. So at higher concentrations itself, it is swelling up and bursting, right? So this is what we mean by the osmotic fragility test. And the same thing, if you put it on to a graph or you extrapolate it here, I will just show you here, right? So here you can see that the concentrations of sodium chloride are plotted against the degree of hemolysis, and this is what we call as the normal range, where you get a sigmoid shaped curve, right? So at 0.45%, you can see that there is absolutely no hemolysis in a normal patient, right? The percentage of hemolysis is just around less than 20%. But at the same 0.5% solution, if you see in a patient with hereditary spherocytosis, you can see that the percentage of hemolysis is much higher, right? So if you see that the hemolysis starts off at higher levels, at higher percentages itself. Okay, so this is about your typical graphs for your osmotic fragility testing. All right, so one thing about osmotic fragility test is that this can be positive in certain other conditions as well, like enzymopathies or unstable hemoglobins also. So that is the reason why it's not considered to be the gold standard for the diagnosis of hereditary spherocytosis. So hereditary spherocytosis, most often you have to diagnose it with gel electrophoresis. But what we would consider to be even more specific as compared to the gel electrophoresis is what we call as the eosin 5 maleimide flow cytometry. Okay, fine. So this is what we call as the eosin 5 maleimide E5MA flow cytometry. So here what we are seeing is that eosin 5 maleimide is basically an agent which specifically binds to the band 3 of the RBC cytoskeleton, right? So if you do a flow cytometry based on this particular eosin 5 maleimide agent, right? So you put it to healthy individual versus a patient individual, right? So if there is a defect, then you do a flow cytometry based on the scatter and you find out that the output is much lower. That means that there is a deficiency of band 3, right? So can you see in a healthy individual, the peak is somewhere here, but the peak is much lower because of the band 3 defect, right? So the peak is lower in an eosin 5 maleimide flow cytometry. So eosin 5 maleimide binds specifically to band. Okay, fine. So this is about the various tests you can do for hereditary spherocytosis, right? Of which would be the best test? I would say, as per today's literature, eosin 5 maleimide flow cytometry is the best test which can be done for hereditary spherocytosis. Then how do you treat it? So in milder forms of hereditary spherocytosis, whenever there is an acute hemoglobin drop or if there is a hemolytic crisis, you give them blood transfusions and you maintain them with conservative treatment. But in severe forms, if there is severe splenomegaly, hypersplenism, then you will have to do a splenectomy, right? So these are the only 2 approved treatments for hereditary spherocytosis as of now. Okay, so this is about hereditary spherocytosis. Now let us understand an enzymopathy which is G6PD deficiency. Okay, so what is this G6PD deficiency? So G6PD is basically glucose 6-phosphate dehydrogenase, right? So this glucose 6-phosphate dehydrogenase is basically an enzyme which is part of the glycolytic pathway. Okay, so we know that the RBC doesn't have a nucleus and it heavily depends upon the glycolytic pathway for its function. So whenever you have a G6PD deficiency, there is a problem with the glycolysis, there is resulting in hemolysis. So this is usually an X-linked defect, right? So this is usually inherited in an X-linked manner. And how does it present? Most often G6PD patients are usually asymptomatic and only during certain episodes they present with acute intravascular hemolysis. There is hemoglobinuria, hemosiderin. Okay, so they usually present with episodes of acute intermittent hemolysis. So let us understand the pathophysiology of G6PD deficiency. So G6PD, glucose 6-phosphate dehydrogenase enzyme, is responsible for the conversion of glucose 6-phosphate to 6-phosphogluconolactone. Right? In this process, NADPH acts to convert glutathione into reduced glutathione. So reduced glutathione basically has protective effects on the RBC cytoskeleton. So if there is a deficiency in this particular enzyme, then what will be lost? You will not have reduced glutathione, which is cytoprotective in nature. So if this reduced glutathione is absent, then there is going to be an increase in the reactive oxygen species, which basically causes RBC damage and hemolysis. Alright, clear? So this is about the pathophysiology of G6PD deficiency. So let us understand that most of the time G6PD patients are usually asymptomatic and there are certain precipitating factors. So we have to remember the drugs which cause G6PD deficiency precipitation. So what are those drugs? We have to remember dapsone. Then you will have to remember trimethoprim sulfomethoxazole. Okay, then remember high dose aspirin. Remember nitrofurantoin. Okay, so these are some of the drugs which can precipitate G6PD deficiency, and very importantly, another anti-malarial drug which can precipitate G6PD deficiency is primaquine, and all of these can cause episodes of hemolysis. Apart from this, G6PD deficiency can be precipitated by infections and fava bean consumption, which is a specific type of bean which is available in the Middle East, and this is in fact epidemiologically relevant because G6PD deficiency is maximally seen in the Middle Eastern countries. Okay, so this is about the various precipitating factors. Now let us understand the investigations which can be done in G6PD deficiency. So in the peripheral smear, what are you going to find? You are going to find something called as bite cells. These bite cells are seen because of irregular staining of the RBCs. You can find that the RBCs are somewhat bitten off. Okay, then there can be irregular pigmentation of the RBCs, irregular pigmentation on granulation of the RBCs, which is called as hemighost cells. So, bite cells and hemighost cells in the peripheral smear is seen with G6PD deficiency. What is the treatment? Most often the treatment is conservative in nature. You just have to monitor and withdraw the offending agent if it is found. Okay, right? So, this is about G6PD deficiency.